took a ride to the end of the line where no one ever goes. Ended up on a broken train with nobody I know, but the pain and the longing's the same when you're dying. Now I'm lost and I'm screaming for help alone. Relax, take it easy, for there is nothing that we can do. Relax, take it easy, blame it on me or blame it on you.
Hi everyone, I'm Dr. Bardia Anvar,
And I'm Henry Okonkwo, PAC.
and we are
Skilled Wound Care.
We will be going over dry skin, also known as xerosis, and the best way to moisturize dry skin. So let's first take a look here on the whiteboard at skin biology. And let's remember that the skin is our largest organ of the body, and secondly, skin is our environmental barrier to basic toxins that can bother our body externally. So we have the environment here, we have the epidermis, which is the first layer of the skin, which is divided into actually 5 layers, with the outermost layer being the stratum corneum. And then the secondary layer of the skin, which is the dermis, which is divided into a reticular and papillary dermis. So what does this mean for skin moisturization? The first thing that we need to remember in terms of the skin is that the epidermis itself is an avascular structure that receives all of its blood supply from the actual dermis coming up. So all the blood vessels are actually feeding the epidermis. All nutrients and all hydration, such as water that moisturizes the skin, comes from the dermis. As patients age, the epidermis actually shrinks in size. That shrinking, along with the cells in the stratum corneum, which are known as keratinocytes, develop holes or leaky junctions in them, which allow actual water, which comes from the dermis to the epidermis, to escape through. And this is a mechanism known as transepidermal water loss. And we all are experiencing transepidermal water loss throughout the day while we are, especially in colder environments, but continuously as human beings, we are actually losing water out of the skin. So that's why it's important for us to rehydrate. In the process of dry skin, which becomes medically known as xerosis, the moisture content in the epidermis falls below 10%. And that's when we start to see dry skin. So now most of us believe, and when we talk about moisturization, we're thinking about adding moisture to the skin from the actual external environment. And that process is done by moisturizers that contain what are called humectants. And we will go over that in a minute. Secondly, though, we can provide another mechanism to moisturize the skin, which is to actually block the transepidermal water loss. And the number one ingredient in blocking transepidermal water loss in moisturizers is petroleum or petrolatum. And this is what we put on top of the skin, and most moisturizers contain in order to hydrate the skin. So actually what we're doing is helping our body moisturize itself. In severe cases, however, we will move on to a humectant. And now Henry will be going over the actual moisturizers and how we use them in day-to-day practice. Thank you. Okay, so our first moisturizing agent that we don't use very often because we have more sophisticated products now, but initially was petroleum based. And the reason why we don't use pure petroleum is because it can be comedogenic, meaning it could actually block your good pores and block skin breathing. So we want to use a moisturizer that has a small amount of petroleum-based moisturization, but not a large amount. So this is your occlusive moisturizer that blocks the transepidermal water loss. So something that would be akin to that would be something such as an Aquaphor. And an Aquaphor And if you look at the packaging here, is really 41% petroleum based. So it's kind of like this one. However, this is 99% petroleum based.
Your next class are your barrier creams, which also acts as moisturizers as well. Starting with calmoseptine, which has menthol and zinc oxide. Zinc oxide is a great barrier cream against water loss, transdermal water loss, but it also comes with menthol in it, which also helps in reducing infection and helping moisturizing the skin. Another one is Desitin, which is very commonly used for diaper rash, so it's very commonly used for babies. But once again, this also has zinc oxide as its main ingredient and acts as a barrier against water loss. Your next class are your moisturizers. Your moisturizers are your emollients, your oils. Cocoa butter, specifically Palmer's, is a popular brand of emollient moisturizer. The common ingredient is canola oil, and this is used to moisturize the skin. Then you have ammonium lactate or amlactin. These are your humectant, and these actually allow water to be drawn to the skin from the dermis to hydrate the body, to hydrate the skin. So these are extremely strong and should be used on patients that have very dry skin, also known as cirrhosis. But your best overall moisturizers are those that have a combination of the different classes. It's going to have your moisturizers, your emollients, as well as some form of barrier. So this brand, your Moisturol, has a combination of the different types of ingredients to allow for optimal skin moisturization.
So when we're dealing with patients in a nursing facility, we may initially see dry skin, and normally that dry skin is located in the lower extremities of the patient because of poor vascular blood flow that's been accumulating over many months and years in the patient. So it's very important to start moisturizing those lower extremities when the dry skin has not become severe and turned into a cirrhosis-like illness. So then we're thinking of things like Aquaphor, or a Eucerin cream, which is kind of a similar product that's put over the lower extremity, and making note that when we shower the patient, or even if you at home, you're showering at home, you want to keep your skin damp when you apply the moisturizer so you can trap the moisture droplets that are already on your skin from the actual shower. So that's why occlusives also work well after showers. Now let's say the patient has continued and the dry skin has become worse and now it's become a severe xerosis. Then we're looking at adding something like an amlactin, which is ammonium lactate, so ammonium lactate based product, a glycerin based product, or a urea based product. Those all are humectants. At humidities over 70% of the environment, they will actually draw water molecules to the skin, and then at less than 70%, like Henry said, it draws the water from the dermis to the epidermis through the process of diffusion. So these are actually very good when the patient has xerosis. But remember, the patient still has that transepidermal water loss problem because as we age, we do not have those tight junctions between our keratinocytes. So what we really want to do is add some type of occlusive, whether it's Aquaphor or Eucerin, on top of the amlactin cream. Usually we apply the amlactin cream, we let it absorb a little bit, maybe 5 minutes, maybe 20 minutes, and then we'll add our occlusive. Then of course, these are actually very good products as well that have a combo of both an occlusive and everything else, and a humectant, and we can use those as well in the facility. Then looking forward, if we have patients that are developing diaper rash, which will be a separate discussion onto in and of itself, we're looking at other creams such as Calmoseptine and Desitin, which actually protect the skin from environmental moisture or toxins that are hitting the skin. So the other thing about dry skin is that it occurs usually in the winter months as opposed to miliariasis, which occurs in the summertime months. and the humidity goes down in the wintertime months, and we're not obtaining as much moisture from the environment, and we're actually losing more moisture to the environment in low humidity types of environments. Also, we have to think about bathing considerations when we talk about moisturizing the patient. So you don't want to sit the patient in the bath for a long time, extensive showers, and then have the patient soak after the shower. You want to you want to have the patient damp when you're applying the moisturizer. You want to pat dry, and you don't want to try to rub the dry skin out of the patient. That's only going to irritate the patient's skin. So no harsh scrubbing on the patient. You want to be very gentle with the skin, and then followed by application of your moisturizer right afterwards, which is usually at that point an occlusive, but a humectant will work as well if the patient has xerosis. How often should you apply moisturizers? Well, there's no limit as to how often you want to apply a moisturizer. Generally, for us, if we're looking at babies, or if we're looking at healthy adults, maybe once or twice a day is enough. For some of us who have good natural working oils in our skin, we don't even need to moisturize. In the elderly population, you're looking at least doing it 2 times a day, possibly 3 times a day, morning, noon, and night, making sure the skin is well moisturized. And why is it so important to moisturize the skin in a patient in a nursing facility? That's because as we get dry skin and xerosis, what happens is the skin starts to flake, and your stratum corneum actually starts to flake off, and now your most important barrier to the environment, your skin, is broken. And it's opening your skin to different kinds of infections. The most scary one, of course, is MRSA, methicillin-resistant Staph aureus, or possibly scabies, making it much easier for the scabies mite to come in and burrow underneath the skin, and then we get those fulminant scabies rashes because the patient already has a compromise of the skin state. So it's very important to moisturize. Examine the patient's lower extremities when they're initially admitted to the facility. Make sure that there isn't any broken skin edges that may be open to infections. And less than MRSA and scabies, you can actually just get a bacterial or a fungal infection that may require you to also use fungal creams, antifungal medication, or antibacterial creams, which are different than antifungal medications. And you will have to really, at the whole part of this, unless you're dealing with mild dryness, is contact one of us at the Skilled Wound Care Program to come in and see the patient and examine the patient and give you the best recommendations as how to deal with this patient. But for anybody out there who has any sort of skin rashes or problems, dry skin, it's very important that you contact a physician, either your primary physician, dermatologist, or somebody who is a skin knowledgeable individual, physician, that can actually guide you in how to properly moisturize your skin. So I'm Dr. Bardia Anvar.
And I'm Henry Okonkwo, PAC.
And we will see you on the field.